This week, in recognition of World Stroke Day 2020, celebrated on the 29th of October this year, we're raising awareness on strokes and the challenges faced by stroke survivors in Fiji. The theme of this year's Stroke Day is Home and Community Care for Strokes. And joining us on the conversation this evening is Dr. Krishna from the Medical Department at CWM. Good evening, Doctor. Thank you for joining us.
Thank you.
And Amy Shankaran, who is a CWM stroke nurse. Good evening and thank you for joining us. Let's first talk about the prevalence of stroke in Fiji as health professionals working in this field. How serious of an issue is stroke?
Thank you, Ziad, for this opportunity. Just for the information of the audience, we are from the stroke unit from CWM Hospital, and we deal with patients who come in with stroke. Just moving a step back further to tell the audience what a stroke is. Now, we've got some models here in the studio for you for the better understanding of the public. Stroke affects the brain, and as we know, it's a very important organ in terms of our daily lives. How we speak, how we move, how we converse with people, how we interact is very important in our daily lives, and stroke affects this major organ. Now, in terms of trends, we've seen that now we're getting many younger patients to hospital. There are unofficial statistics which report that over 10 years in Fiji, in our 3 hospitals, there has been around 800 cases of stroke. But remember, these are unofficial statistics, and we could have many others out there in the public who have had a stroke. And we'll go on later to discuss what are the signs and symptoms of a stroke. But in actual fact, we will see a stroke patients at our hospital every day.
Because a lot of people who suffer, who have suffered from stroke, it doesn't always result in death, but it does result in other chronic health conditions that lead to serious effects down the road, right? Talk to us about the risks associated with stroke.
Okay, one of the interesting things about stroke is, unlike if you have a heart attack, so basically if you have to define a stroke, it's an attack of the brain. And in the general public, the terminology of a heart attack is taken better than if you tell them a stroke. And so a stroke is a death of that portion of the brain just because one of the blood vessels supplying the brain has given up. So the two main causes of having a stroke are if there is a blockage in the blood vessel or there is a burst blood vessel. And the risk factors are many. And in Fiji, diabetes, hypertension, smoking, being obese and eating and having an unhealthy lifestyle are all contributing factors to having a stroke.
Do all of these factors contribute equally, or are there certain factors, especially in Fiji in our context, that stand out more than others?
Now, I would say all of them contribute greatly, but if you look at different age groups, you look at the different prevalences of the risk factors. Now, diabetes and high blood pressure are the main ones that we have to address. And more so the high blood pressure, we call hypertension, when we come to our patients, when we see them in the hospitals. It has been an epidemic, and if you've looked at other specialists in their field, they will say that before we used to have those patients who were aged, between 60 to 70 coming in, but now we see very young ones who come to hospital in their 30s and 40s. And we've had a young 12-year-old with a stroke, and it's not uncommon to see these young ones. So if I had to categorize them in terms of the most significant causes or risk factors for stroke, it would be high blood pressure, diabetes, smoking, obesity, and so forth.
So there's also something that a lot of us don't realize, that there's different types of stroke, and there's something that a lot of people refer to as a mild stroke, and then once they have that attack of what they deem a mild stroke, they tend to brush it off, saying that they've recovered quite quickly and they don't take all of the precautions that are prescribed to them by the health and medical service providers. How often do you see this happening, and is it a bad thing for people to just brush aside what is called a mild stroke in layman's terms?
Thank you, Geraldine. Yes, a mild stroke, I wouldn't want the public to believe that there is such a thing called a mild stroke, although in medical terms we say that's a transient ischemic attack of the brain. And that's whatever function or let's say whatever you're able to do and you can't suddenly do, let it be speaking, moving around, or your vision, or the way you are. And I've got Amy here with me who has a diagram to let us inform the public in simple terms, what are these main things we need to look for when we're out there? Amy, if you could help us, please.
Okay, so like Geraldine said, the transient, a mild stroke, but we call that a transient ischemic attack. So for a stroke, normally these are the signs that you will look for. We have an acronym, so it's FAST. So F stands for face. So the person, the client that we'll have would normally have drooping face. So how we would ask them to do is ask the person to smile and then just see if their face droops to the side. So A is for arms, and then you ask the person to raise both the arms and then see if one of the arms they appear weak or they might just go down. And S is for speech. You ask the person to speak and then you'll notice if it's slurred or if it sounds a bit strange. Sometimes they might say things and it might sound funny. And T is for times. That's how, if you notice these things, how fast you bring them to us so that we can have it seen and checked out. Same thing goes for a TIA. They will experience signs of this. They'll have facial drooping, they'll have weakness in the arms, and they'll have slurred speech. So these three can happen all at once, or maybe two of these happen. But the thing is, the signs, they resolve, the symptoms resolve within 24 to 48 hours. But we ask them, you need to come, if you have this, you need to come to hospital as soon as possible to have it seen.
We'll carry on this conversation when we come back in our next segment. Stay with us. So carry on the discussion from where we left off, the FAST model that you have for assessing whether or not someone has suffered from a stroke. I'm interested in the time. You mentioned in the last segment that it matters how quickly a person receives proper or adequate medical attention. So what's the adequate time frame for someone like that?
You know, when we talk on the brain, if we deprive of the brain of oxygen and its blood supply, just as soon as we do it, the brain cells start dying. And as soon as the family member recognizes these, we would like to tell the audience they need to come to hospital to see us. If they have a facial weakness, if they have a face which is not looking right, if they've got an arm which is being weak, if they are having difficulties speaking, as soon as they recognize this with the patient, they should not brush it aside. They should come to hospital to seek us advice, because when you come to the hospital, we are there to help you. In terms of help, then we go on to investigate further in terms of what pathology or what's the part of the brain which is affected, and in terms of imaging and stabilizing your blood pressure, your sugars, and looking at blood tests to help.
Sometimes it can be a little difficult to, I guess, for laymen, for non-medical people, to understand the link there is between what you eat and how much blood supply goes to your brain. So you've brought along some of these really useful diagrams here. Talk to us about how things like the risk factors you talked about, obesity and the level of cholesterol in your blood, how does that lead to stroke?
Thank you. Yeah, I must thank the Fiji National University and the medical department for allowing us to get this model. So like when you said, these are a bigger model of how the blood vessel would look like. These are different kinds of blood vessel. But if you flip it around and you look at the caliber of the blood vessels, basically everyone knows this. If you're going to eat a lot of fatty food, it's going to accumulate inside these blood vessels and it's going to block it one day or the other. So a diet has a big contributing factor, like you asked about risk factors, and we are not on the right pathway in terms of diet if you look at the general population at large. And when we put that in perspective, when we look as well to the heart model, this is a model of the heart, and if you look at it, it's surrounded with many blood vessels. So if we are not looking after the blood vessels in terms of our risk factors on sugar control, on blood pressure, on our diet, it's going to in the end affect the organs that it's supplied. And the theme here is on stroke, and it's very important that we look at that perspective on what we put on our tables every day in terms of what we're eating and how it's going into our bodies and how we are in terms of a healthy living.
Doctor and Amy, this is for both of you. We've already heard that we've got a very, very alarming rate of cases that we come across with strokes over the past few years. The trends show that it is increasing. You've also mentioned that there are younger people who are now presenting signs and symptoms of having suffered from a stroke, and those who are at more risk of having a stroke attack. But with that in mind, what is the major contributing factors, do you think, that's making all of these younger population people more at risk? I mean, you happen to have people who say, well, no one's in my family ever had it, and I'm really young, so I'm not at risk.
I agree. I think if you look back to our grandparents and great-grandparents, they were very slim, thin people. But if you look at us and probably the younger generation, we are overweight and we are obese, and there are many contributing factors to that. I think the focus in this generation or in our older generations were quite different. What is available to the population now wasn't available to our great-grandparents or grandparents, and the decisions and the choices we make in terms of the food we eat, in terms of their nutritional value, and in terms of their fat content, I think it has to be elaborated, and our goal here is to tell the people in Fiji that we have to make better decisions on what we eat.
But Amy, when you deal with those who have had a stroke, of course, it's not just the food. There's also this paradigm shift where we've seen people who are not being very active. They're not leading very active lifestyles. There's more stress. There's more mental health issues that they do not deal with, and it causes a lot of burdens to them in their daily lives, which is why they don't really take their health into consideration.
So we would advise them, you should take ownership of yourself. We work longer hours now. There's a lot of stress, you know. So we ask you, you need to take ownership. You can't wait for someone to tell you. If you know that you're going down the wrong path, or like for your diet, we are all well educated, especially for, the younger generations. And also from, it can start from home. Our kids can learn from the parents. It's a learned thing. So if we start now, we can tell our kids how do you live, healthy lifestyle. So it's more like you take ownership of yourself, and it's a learned experience. So if you start young, as you go by, you probably lead a more healthier lifestyle.
Now, the both of you, as well as some of the other guests that we're going to have later on in the show, you're part of the CWM Stroke Multidisciplinary Team, right?
Yes.
How did this group form, and what sort of stuff do you do in this group?
Yes, we are a group of hardworking, tireless people, and I'd like to thank the brainchild, which is our head of department, Dr. Charya, and the head of physio, Koto, who have been leading this all the way. And we are just advocates. Basically, we have doctors, nurses, we've got physiotherapists, we've got dietitian, we've got a nurse practitioner, and a community rehab physio, who all come together weekly to discuss all our inpatients who are in hospital in terms of how well we can improve their quality of management and their service, and also start deciding on how we can bridge their care after we have discharge them from hospital. Of course, like you said, when we come to the hospital, we look at the patient's deficits, what they may be. We do imaging. We've got, fortunately, CT scan here in Fiji and an MRI machine compared to the rest of the Pacific. We're doing very well in terms of imaging. We start addressing their blood pressures. We look at their sugar control. We look at certain blood tests to see if they've got high cholesterols or their lipid profile. We say the fat content in the sugar in the blood is at an adequate level, and we start the medications if they need blood pressure controlling medications, if they need statins, if they need fat medications. And we are the stroke team, and we are trying our best to help bridge that gap. Once we have the patients go home, we have certain, you'll have guests later on who will describe how we bridge that gap in terms of care. And you're not just left alone. We are there for you.
When we come back from our break, we'll talk to a physiotherapist who is also part of this team. Stay with us. back. In this segment, we're joined by Tao Telai, who is a physiotherapist that works with stroke survivors at the CWM hospital. Tao, thank you very much for joining us.
Good evening, thank you.
My first question actually is to Dr. Krishna. Talk to us about when it's necessary for a physiotherapist to come in and what sort of problems you face with patients that warrants the intervention of a physiotherapist.
Thank you, Ziad, for that question. As you know, the brain is very complex. It controls so many parts of your body. And of course, we have patients who come with speech problems, swallowing problems, and in terms of mobility, that's one of our major places where we have the physio, who plays a very important component in terms of trying to assist our patients in terms of getting quicker in terms of the ability to move their arms and legs. And when you said how earlier should we have them, as soon as we are able to stabilize our patients and get them into the hands of the physiotherapist, we do so.
So next to Ms. Telai, what happens when you get handed over a patient from the doctors?
So at CWM, the stroke physiotherapists, we have developed a guideline into how we carry out our practice with our stroke patients. So we usually, our first assessment should be carried out within the first 72 hours, where we have a form that we fill. So this form will assess all the abilities that the patient has and the abilities that they do not have, and also their activities of daily living, if they can feed on their own, if they can dress themselves, and we have scores for that. And in that form will also allow us to set goals with the patient. So in the first 72 hours, we will come in, explain to the patient our role as a physiotherapist, and also importantly to their relatives, their caregivers, and explain to them why it's important that they need to exercise, and also that it's important that the relatives are also aware of the exercises. And we also advocate on identifying a primary caregiver for the relative, because we've noticed that when the caregivers change, care is not the same throughout the patient's, the client's stay in the hospital and when they go home as well. So the earlier that we get the relatives or the family to identify a primary caregiver, the better it is for us to teach the caregiver the exercises and the rehabilitation for the client.
So interesting that you noted that you need to teach them the correct procedures in terms of physiotherapy, because it is physiotherapy. It's physical retraining of your muscles, of everything. Motor skills and whatnot have been diminished. And it's difficult for most of us in the Pacific to actually take advice from someone who may not be a doctor. Not that we are belittling what physiotherapists do. With that in mind, do you come across instances where there's home remedies where they do, sometimes deviating from the set plan that you've given them?
Yes, Geraldine. Most of the families encourage massages. We usually tell the relatives, we also learn how to massage. So for massaging, we usually recommend relatives to massage patients when it comes to muscle tightness. That's when we recommend massaging, and we also teach the family how to do it. Getting people to massage the patients without our knowledge or sometimes puts the physiotherapy rehab plan for the patient back. We sometimes, our progress plan does not progress because of outside treatment that we are not aware of. So usually.
So just by way of example, because you explained that entire procedure to us, and using the equipment that you've brought here, could you explain to us what happens if, let's say, after your assessment, you've given that person a score, and the main areas that they need work in is restoring their ability to walk and their speech function. So what does a physiotherapist do then, and how long will this take?
Okay, so for speech, stroke patients usually come with weakness in their facial muscles. So for speech exercises, we usually get them to do facial muscle exercises, smiling, making angry faces, making faces, using your eyebrows, cringing your nose. And also we advise them to use different textures on the patient's faces. So you can have like ice cold therapy for their face, or you can use a soft brush or even powder. So different textures will help with their facial muscles rehab. And for walking, for someone to get back to walking, we usually assess their bed mobility first. So for stroke patients, if they can, we start with physiotherapy in bed, once they are able to sit up in bed independently, we get them to sit on the edge of bed. And from the edge of bed, the progress after that is to use this walking frame. This is the walking frame that we will progress the patients into getting them to start standing again. If because of the stroke they cannot stand or their balance is poor, we prescribe wheelchairs. So that's one thing that, depending on the stroke and the client's abilities, if we see that the stroke has affected the area which controls their balance and they cannot sit on their own, we prescribe wheelchairs. So we do wheelchair measurements, and the Spinal Injury Association is our partner that supplies the wheelchairs for our patients. And we usually get the relatives to take the wheelchair measurements to them, and they will provide wheelchairs.
Great. Dr. Krishna, once a person has been, assigned the proper medication, what other advice do you give stroke survivors that will go back home, will be discharged from the hospital, will be receiving care at home? Advice about the changes that they need to make in their lifestyles and how they can achieve, I guess, the road to recovery?
Once we see the patients, the compliance to medication is one of the biggest issues we face. Sometimes we give a whole lot of medications without the patient understanding what they are for, and we do encourage them to be more educated on what treatment is given to them at the hospital and ask us questions. Sometimes we do not ask that many questions to the doctor, so we encourage them, first of all, to take the medications, what they are for, and when to take them, and if they are not able to understand them, and educate the family members to take them when it's required. The other thing is the follow-up to our clinics. We have many defaulting patients who don't come to our clinics when they are to come, getting back to their remedies they might have in their villages and out there in the community, which then does set back the rehabilitation we are working so hard for them to get, because stroke basically is coming on time, getting the right treatment for the stroke that you have, and getting that part of the body functioning in terms of the speech and mobility. Earlier it was thought that if that portion of the brain is deprived of oxygen, it will not recover and do whatever it was supposed to do. But given if you are going to train it back again, it will have certain abilities to get that process which was not functioning before.
Well, Dr. Krishna and Ms. Delai, thank you very much for joining us. Unfortunately, we've reached the end of this segment. After the break, we'll talk about post-discharge care. But thank you very much for joining us. We're now joined by Ms. Elizabeth Fong, who is the president of Counterstroke Fiji. Good evening, and thank you for joining us, ma'am. And also joining us is Mr. Deepak Ronil Prasad, who is a nurse practitioner for the stroke team at CWM. Good evening, sir. Thank you for joining us. So to Ms. Fong, for someone who isn't aware, what is Counterstroke Fiji? Who does it work with, and what are its areas of focus?
All right. Counterstroke Fiji is a voluntary organization that was set up in 1988 by the late Captain Stan Brown, who had experienced a stroke. And he realized that there were many people out there in a similar situation who weren't getting help after they left the hospital. And really what he focused on then also was prevention of stroke. And so that's where Counterstroke really comes in, awareness and prevention. But we do have programs to support those who are survivors of stroke. And in that way we do talk shop every Thursday where survivors come in. They have their sugar readings taken, they have their blood pressure taken, because you heard Dr. Pernille say that these are NCDs that lead to stroke. So when they have that done, plus it's more of a social gathering for them to come out of their homes, talk with others about their situations. And so that's what Counterstroke is really about, prevention and awareness, and doing various things to achieve that, with workshops for carers, workshops for those who are survivors. And we work with care people in the community also.
That actually brings me to my next question. The sort of work that you do with the CWM Stroke Multidisciplinary Team, So these are doctors and nurses and physiotherapists, and you work a lot with patients. So I'm just trying to understand what that relationship is like.
Well, for us to be successful, we need their input. They're the medical experts. They advise us. And since the stroke unit was set up with Dr. Shrishacharya and Dr. Pranil, we've come together much better. We have a much closer working relationship, and each Tuesday, our staff member, we employ one staff person in the office, she goes to the hospital, communicates with the sister in charge to have a chat with the patients if she's able to. If she's not able to, then we give them an envelope, a package with managing after a stroke, and we give them brochures on how to contact us. So we're keeping them informed. So that's our link. And often we get calls from people, because we have a website, to come and help.
Ms. Fong, if we were to look at the incidence rates of those who happen to be stroke survivors, and once they get some sort of mobility or some sort of independence after they've suffered an attack, and they're able to move on and have some sort of rehabilitative program that's been prescribed to them, there's also something that Dr. Pranil had mentioned earlier about defaulting treatments, about patients and also survivors not going back for the treatments that have been prescribed to them. What does Counterstroke do in instances like this? Do you facilitate them going back to treatment? Do you talk to them about that?
If we're aware of it happening, yes. And through Talk Shop, we have a network with the nurses and that. So we do reach out to them. And through our brochures, we say, please take your medications. Please remember that what you eat affects your cholesterol levels that can impact. So we're always recreating the awareness for prevention of the stroke. But that is a challenge when they don't come forward. But if we know and we see one of our people not turning up to Talk Shop, we'll ask, has anybody been in touch? Otherwise, we will be in touch with them to ask them what their situation is.
Now, Mr. Prasad, you're a nurse practitioner and you work with a lot of stroke patients. This involves actually going out to their homes. And I just want to know what the aim is. I think the program is called Hospital Away from Home?
Yeah, Hospital in the Home.
Hospital in the Home. Could you talk to us about that?
Okay, actually what happens that when these patients discharge from the hospital, one of the medical teams, the consultant, they usually refer the case to me. So I will assess the patient if their criteria that's really suitable for me to accept in the Hospital in the Home program. So once I go to their place, I already have taken their consent. I see them on a routine basis, how they deal with stroke, how they are coping with stroke. Because these people, some of them are the breadwinners of the family. So once they go back to their home, they are not in terms of holding powers in the family, so they in terms of depressed, there's no support for them. So I do look into their health status as well as their mental health and as well the whole well-being of them. So I also arrange for a social worker in terms of providing a social welfare assistance. I do arrange a social counselor who can do counseling services for them. Even I monitor their blood pressure at home, I monitor their sugar at home, and when the blood pressure and the sugar is in a control range, so I do discharge these patients back to the community. So it's like I'm bridging the gap from the hospital to the community, so that our stroke survivors are not left behind. Like they have a system in place that we are there for them.
Is this a new initiative, Hospital in the Home? Is this something that you've started doing recently?
Yes, there was a hospital in a home which was looking for surgical patients only. Just recently, with the initiative of Ministry of Health, last 4 months, they came up with this to introduce Hospital in the Home for medical patients. So I do take medical patients, especially stroke cases, new onset of stroke cases, and patients that can be managed back in the community.
From your experience in working with these stroke survivors, what would you think is the greatest challenge that they face once they're out of the hospital, once they've been discharged?
The greatest challenge is that because before they had stroke, they were a normal well-being, like for me and you. They were walking, they could have gone anywhere they could have, but due to the severity of the stroke they had to stay back at home. They are dependent on somebody to feed them, actually, to dress them up or to groom them. So like the challenges they face, that sometimes they are left behind. So we are there to inform the carers, to motivate them, and then to bring back them to livelihood in the community, so that they can maintain productivity and maintain wellness as well.
Still a lot to discuss. We'll be back after a short break. So in our final segment, we'd like to talk about something that was raised earlier by both Ms. Shankaran and Dr. Krishna, the importance of having someone there as a primary caregiver. And even when there's a primary caregiver, the level of care that should be consistently maintained. And they spoke about the challenges in sometimes finding a caregiver or finding someone to give that level of consistent care. To either of you, how important is it for someone to always have, I guess, a support system, a network of people that can be relied upon?
Okay, if I may answer that from Counterstroke's perspective, it is most important. People tend to look at stroke and the physical side of the impact of stroke, but the psychological is the part that determines the path that they will take to recovery. So having someone who they're comfortable with is very important. So what we do at Counterstroke, we have a book called Managing After a Stroke. So this has been put together by physiotherapists, and we have a physiotherapist in our talk shop group. So when those come to our talk shop sessions, they have it. But they will also go to people's homes and show them how to do this. So we run workshops for carers. We get funding from government. We fundraise ourselves also. And we're always looking for volunteers who can come and go and spread the word about awareness. But to get back to what the physiotherapists do, they will go home, talk with them, and show them how to become independent members of society, because that's the aim. And if you look at the statistics, 1/3 of the people will have a stroke and recover. 1/3 will live with some disability, and some won't recover. So that's high. The statistics today show that 1 in every 4 persons in the world will have a stroke.
So hypothetically speaking, either one of us from the 4 here is at risk of having a stroke.
Yes.
So Deepak, you said earlier that you are pretty much bridging the gap between the community and also the medical service providers, which is the hospitals. How often do you come across cases, or how often have you seen instances where someone who is a stroke survivor has been discharged from hospital, they're sent on their way home, and then they either refuse treatment on their own, or they're encouraged by their family members or those that might be their carers to not continue with treatment, to just sort of give up?
Okay, thank you. I have a set of consent before the patient comes to my unit. So the patient has to consent that he will be abiding by the care that we will provide to them from Ministry of Health. And if the carer goes home and he opts for care beyond medical health, so we will allow them, but in a point of time we would not, because if anything happens to them, then Ministry of Health won't be accountable for them. So that's why the care will be stopped.
Now, I hate to be one of those scare tactic, but sometimes unless you actually get to the root of the problem and the end point of something like stroke, which unfortunately may result in death, people just will not wake up and see the consequences of their lifestyle choices and their behaviors. For someone who is at risk of contracting or having a stroke attack, what are the main things that they need to do right now? Because as Elizabeth said, 1 in 4 people is at risk of having a stroke.
As Dr. Pranil has mentioned earlier, that prevention is better than cure. So we should work on the prevention side. So our lifestyle factors that we can modify, smoking, can stop smoking. Even if you're drinking alcohol, you can limit the standard drinks 1 to 2 glasses per day, but that doesn't stop you having stroke. even stress level that you have in life, you need to reduce the stress level. Modify your diet, eat healthy foods, do exercise on time. With this, if you are a medical patient, if you have a medical conditions, high blood pressure, you have diabetes, you need to take your medications on time. You need to do regular exercise. You need to come for follow-ups, regular checkups, so that we can prevent you having stroke.
If I could just add to what Deepak said, leading a healthy lifestyle and doing all the things right is what we'd like to see everyone be conscious of. When everyone I have met has had a family member or known of a family member who's had a stroke, they've observed how it has changed their lives. So at Counterstroke, this year's theme for World Stroke Day, reaching out to the community, is don't be the one. So of the four of us sitting here, none of us want to be the one of that four. So I say to the gentlemen who like their grog sessions, before you start a grog session at 6 o'clock, why don't you all take a walk around for an hour and do exercise, watch what you eat. There's too much fast food available these days. We're on the run, we're eating like that. So if you counteract that with some exercise and keeping oneself healthy through good rest. You may drink grog, but have 6-7 hours rest to cope with the next day. So from Counterstroke, ours is prevention. We want to prevent it through this, but if you do, we're there to put you back on the road to recovery. Thank you.
We're about to come to the end of our show, and just a very final question to both or either of you. If there is a stroke survivor watching us right now, or if there is a primary caregiver watching us right now, what advice would you like to give to them?
From stroke team, from our advice is that these caregivers are not trained. They don't have any certificates that they need to care for the stroke patients. These are the ordinary people, the relatives or family members of that stroke survivor from the hospital. I really thank them because they really grasp whatever is taught in the hospital for them to look after these patients, like our survivors back at their home. And we have seen a lot of changes in our survivors. They have really done well. Some of our patients that did have stroke, now they have recovered, and some are still recovering, and hopefully they are really doing well. Thank you.
If you've had a stroke, come and join Counterstroke. If you're mobile, we encourage you to come to our talk shop sessions every Thursday from 10 to 12 at the NCDP Center. And if you are a carer who has not had any training at all, when we offer our workshops for carers, where we show you how to use the book Manage After a Stroke, we encourage you to join up. It's free. When we offer these workshops, they're free, and at times we join the medical people and go out into the clinics and that. So please keep a lookout. We post it on Facebook, we post it, and we send it through the news. So both stroke patients and carers are welcome to come to Counterstroke and encouraged, along with the rest of the community, to join us as volunteers.
Ms. Fong, Mr. Prasad, unfortunately we've reached the end of our show. It's been a great discussion. Thank you very much for joining us.
Thank you.
Thank you.
And that's all we have for you on the show tonight. Thank you for joining us. Have a good evening.